So we are talking about perioperative visual loss. Let's look at this gentleman, clinico-radiologically a cervical myelopathy, affecting his activities of daily living, needs surgical intervention. Counseling done, CT, MR, preoperatively confirm my diagnosis. Patient and surgeon both agreeable to the fact that he needs surgical intervention. Does he have comorbidities? Yes. Like anybody in their 50s or 60s, he has hypertension, diabetes, which is controlled. Slightly unusual, has had deep vein thrombosis, which was treated a couple of years earlier. He has 2 stents in there, has been on clopivas, which has been stopped by the cardiologist for the past 5 days, considering that he has impending surgery. He has some other comorbidities, and that will usually happen if you're operating on a friend or a colleague's parent or uncle. He is usually an elite businessman. My patient had a cell number ending in 99999, came from Andhra Pradesh. His daughter was in the United States of America. His nephew was my fellow when we did this surgery. And she was in touch with him. She was a medico there, but she was surprised. She had unrealistic expectations. She had a guilt feeling that she's not around. She was absent from care, obviously. And she wanted to reassert her role as the educated doctor in the making in the family as the caregiver. We evaluated him, discussed everything threadbare, spent a lot of time counseling, and did a posterior decompressive laminectomy. And this is now almost 16 years back, 17 years back. It was a quick in, quick out job. Surgery was uneventful. Post-op patient went to the recovery room, which is just in the next room, and felt that he could not see well from his right eye. This is what he shared with us maybe 10-12 minutes after he was extubated and in the recovery room. We were by then very comfortable and happy that he had started moving his upper and lower limbs, because that's what we normally look for, and were having our second cup of tea. What next? A post-operative catastrophe in spine surgery. Whom do you call during such a situation? And this is open to my colleagues who have shared this same predicament as I. Do we call the anesthetist? Do we call the ophthalmologist? Do we call a neurophysician? Do we get a cardiologist in? How do you handle the patient? How do you handle the family who's immediately outside? And obviously somebody who's in another time zone, another continent. Literally, at that time I didn't know anything about this. The eye cannot see what the mind does not know. I was unaware of this because I'd never had it earlier. I started thinking, with the remote or the relatively less knowledge that I had about perioperative visual loss then, not read much about it. Was it something wrong with my positioning, too much of a head load? Did I damage the eye? Was the intraocular pressure high because we put him in that position? Was he having sustained hypotension? Did I insist on the anesthetist reducing the BP? Was it a thrombosis which may have happened? Was it venous in origin, arterial, embolus? Was it neurogenic, cardiogenic? And did anybody else have the same? I worked in a setup where I still work, which is Lilavati Hospital, and we'd had 2 to 3 such instances in the past, but it was my first experience. This is my situation then. I went to that desktop which was kept in Lilavati, tried to get that cable in to get some internet and some information. It was a struggle. We didn't have access to Neeraj Bijlani at that time to help us. Made as many calls as I could to my friends around, asking if they had the same. None of them had. Time was passing away. I was very concerned that more than the patient would pay me, I would have to pay, because I would get arrested very soon and I would be handled or manhandled in court. This is the way it looked. Very few whites, lot of it grey, and maybe something black. Prone position, as mentioned by Raghu in the morning, commonest position that we take. We secured the patient. There were 4 people who had turned the patient around. We put TED stockings for all patients. We had turned the head under supervision because it was a cervical spine pathology. The arms were well by the side and strapped well. The chest was in straight bolsters, and we at that time had just started using these gel pads at Lilavati. We reaffirmed that we had used a foam and not a horseshoe. I was not one of those who used to use pins at that time, especially not in these cervical myelopathies. Hence, we actually had something like a foam, and we had one of those mirror ones to have a look at the face as well. And my anesthetists were pretty certain that there was nothing amiss. I didn't use one of those frames there. Did I put traction? No, I did not. But did I keep a little head eye? Yes, I had kept a little head eye, which I do still, and I've always done since then. Did I keep my neck in neutral? Yes, it was neutral, not flexion, not extension, just left it the way it was. I read that we could have ophthalmological, neurological, and myocutaneous complications, but I was worried about this ophthal one. I realized then that it could be either an ischemic optic neuropathy, posterior or anterior, or it could be a central retinal artery occlusion, or something even worse called cortical blindness. Read more. Was my patient coming under one of these? Was he obese? Not really. Was he male? Of course he was. Did I use a frame? No, I didn't. Was the anesthesia prolonged? Well, he was under anesthesia for about 3 hours. If you say it's prolonged, fine. Did he have blood loss more than 4 liters? No, he did not. Did he have hypotension? We checked through all the papers. There was nothing there that he had any hypotension. MAP was 90 plus all the time. Did I use too much of crystalloids versus colloids? Probably, but not too sure. Did he have atherosclerosis and diabetes? Yes, he had both. Well, did he have any external compression seen? No, he did not. So could it be central retinal artery? It could, despite the fact that it was not seen at that time. None of these were found. He didn't arrest, he didn't have an embolic phenomenon during the procedure. Hence, it was not a dense cortical, and it was unilateral, not bilateral. Perioperative visual loss can be usually due to retinal ischemia. It could be a central retinal or a branch retinal artery which is affected. Central retinal is usually one side. Branch can actually get worse at times. Why does it happen? Well, it's unattended to. At times you're moving the neck, and especially if you have a horseshoe rather than a foam, you may actually cause some mechanical compromise there. Branch retinal artery is actually an embolus or a spasm which can go, it's an end artery, it's a small artery, and it can cause neurology far denser and irreversible. Earlier I thought, and that is what literature said then when I read 15, 18 years back, that cardiac patients had as much as prone position of spine. Now we have literature which says that maximum is prone position of spine rather than cardiopulmonary and other procedures. So please be aware of this, that we can have maximum percentage of patients who will have POVL. Well, it's said that ischemic optic neuropathy, the AION or PION that I spoke of in the beginning, is the commonest. Central retinal artery is less, although it's been regarded as the major offender. Hours of prone surgery, 4 hours plus, which is 5 hours, is danger zone. So try and keep your surgeries to less than that as far as possible, or stage them out if you have to do it. If you have patients who are between 50 to 70, those are the guys who are the most prone. Before or after that, the chances are less. What happens? Well, both ways, mechanical or ischemic, both of them finally go down to the retina or the retinal artery, which either has a spasm or a hypoperfusion, followed by a sudden reperfusion. Please understand, similar to the cord, a hypoperfusion followed by a reperfusion type of an injury, which causes that snap and you lose your vision. What is the prognosis? It's guarded. As you saw, few of us found partial or complete recovery, few of us did not have any recovery. What is it that we can do? Well, you can ensure that the position is good. A lot of people try to give a local massage. The ophthalmologists do that, which can actually push an embolus if it is there. Acetazolamide, limited opinion. Some people say use it, others don't. That's Dimox. That's the same thing that we're using on. Oxygenation, yes or no. Fibrinolytic agents, if the patient has a cardiac coexisting pathology, give it. It may not work otherwise. That's about all. Positioning is what you can do. There's an ASA task force, an anesthetist group, which came out with a lot of recommendations of what we should do, how we should preoperatively do an opthal checkup in the high-risk patients, how postoperatively immediately you should do finger counting, etc. there in the OT and check whether it is. Role of steroids plus minus, we tried it at that time, I don't think it works. Role of cardiac sort of digoxin type of drugs, no more regarded as useful. Restarting blood thinners, as I said, only fibrinolytics you can use, but in cervical spine, you start a blood thinner, you'll have paralysis 2 days later because you'll bleed there. So these are all very, very dangerous situations. Avoid deliberate hypotension during the procedure for sure. Reduce your surgeries to as limited time as you can. Use a team member with you who keeps telling you where you're going and who has a low power distance index. Gentleman was talking about the airline industry. Yes, have an assistant who's like your co-pilot, but who can at PDI of 1. What is PDI 1? PDI 1 is where the person next to you, in the very first thing that he tells you, Ram, you are wrong. In our country, Air India has PDI 5. Malaysian Airlines has PDI 6. While the American and British Airlines have PDI 2 and 3. What does that mean? That suppose my junior has to point out a mistake to me, the first thing that he will say is, sir, do you think we are going as well as we went last time? He will ask 6 questions before he comes and tells me, Ram, you bloody cut the cord. He better well say that before I touch the cord. So that is called PDI index being low. Have somebody with a low PDI index who can pick it up before you're doing something wrong. Positioning ho gaya, blood pressure, hypotension ho gaya, any one of those or all of that. What did we do? I've had 2 such instances. What did I do in both my instances? All the above that I told you, but finally I prayed, and prayed. One recovered completely, one recovered partially. As I've always said, and I quote Fritjof Nansen, the difficult is what takes a little time, the impossible is what takes a little longer. You will have to counsel, and counsel, handhold the patient. Ever tried, ever failed, no matter, try again, fail better. We all will have complications, as rightly mentioned by Samir. Either we operate or we don't operate. If we don't operate, we have no complications. Otherwise, we'll all have complications. And we'll revisit this time and again. Samir got very emotional talking about his patients, and so do I at times, because these are things which remind us and things which we cannot really forget and which do disturb us. Always be open to learn, unlearn, and relearn. A lot of skeletons will tumble out of our cupboards when we open them for dusting them. But come out and stand there, because please remember, success is not final, failure is not fatal. It's the courage to continue that counts. So stand up, fight it, and face it. Thank you all for a very patient hearing.
Thank
Any
you, Dr.
questions
Ram.
you have,
Any
I'll be
questions?
happy to take the answers. Yeah.
Since a long time, I have been using a special position for all prone positions, where put at tongs, place those C supports, we use it for the THRs and arthroplasties, and place the patient. Tongs are supported on the C clamps. You get a beautiful, the whole face free. No pressure on the eyes, maxilla, the lips, everything open. If on that, if you still feel that there is a little hyperextension, if still on that, if you still feel there is hyperextension, just put a little chin support to give that military tuck positions. And believe me, I may be a little more fortunate, but I've been operating for 12 hours and more for a very long time, over almost a decade or more. Very fortunate not to have any complications or even a sore on this thing also. I had one on the lips because of the manual pressure, but I think for the younger crowd, yes, possibly the position is extremely important.
No, I totally agree with you, sir. I have nothing against this. I'll also tell you that I had these 2 within 2 years at that time. I had not had any before. By the grace of God, I have not had many later. But Leelavati Hospital had 12 patients within those 5-6 years. Again, we've not had later, we've not had before. So there was something which we have still not been able to point out. And we had it among our entire group of spine surgeons. There were neurospine. So there is something which was wrong, which we have corrected. I don't know what we've done. But we are trying to just suggest that these are all the things which can move against us. I mean, I know Dr. Atul Goyal, who does that for all his patients. He puts the tongue, and you guys have never had this problem. So I appreciate that. It's just that I'm trying to get literature together. I don't know where I went wrong.